Alaikum. Good morning, everyone. Um, to continue, the first presentation was about the ASD. This is the second presentation about the VSDs. Um, as similar to ASD, there were different types of ASDs. Similarly, in VSDs, there are different types. It depends on the number, so it could be single or could be multiple VSDs. Sometimes it depends, the classification is according to the location. So it could be in the muscular part of the interventricular septum, as you may see on the four-chamber, right atrium, left atrium, right ventricle, left ventricle, and here is the interventricular septum, which is a muscular part and a membranous part. So if the defect is in the muscular part, they call it a muscular VSD. If it's in the membranous or around the membranous, so they call it a membranous or perimembranous VSDs. Sometimes it's associated with other congenital anomalies, like we mentioned in the ASD, associated with the ASD premium, and they call endocushon defects. So of course, it depends on sometimes on the size of the VSD, whether it's a large VSD or a small VSD. Sometimes the muscular VSDs are restrictive because during systole, the contraction will prevent and restrict the shunt. And of course, it's important to discuss the size, the location with the interventionist, because sometimes they would be able to close percutaneously rather than surgical options. Similar to an ASD, we need to comment on the type, the size, and the hemodynamics. So it's important to exclude pulmonary hypertensions, any associated congenital anomalies, whether the shunt amount is correlating with the size of the VSD. So if there is a large VSD and there is no much of a shunt, this might be an indicator of an Eisenmenger syndrome. So it's not happy news whenever you see that the shunt is not big but the VSD is a large VSD. Similar to this picture or this patient where it's associated with an ASD premium, and so this is an endocardial cushion defect. As you may see, the mitral tricuspid are on the same level. Sometimes they form only one inlet valve with 5 or 6 leaflets, and sometimes the inlet is not balanced, so it's more draining blood toward the right ventricle rather than the left ventricle, and then the other side will be more hypoplastic or smaller in size. So it's important to comment on pulmonary hypertension, amount of the shunt of the blood, associated congenital anomalies, and the size, type of the VSD would decide whether this would be closed surgically or percutaneously. Some other pictures, and it's important to know that that's the opposite to an ASD. ASD would lead to dilatation of the right atrium and right ventricle, but in a VSD, this would lead, it's a defect that would lead to dilatation of the left atrium and left ventricle, because the blood is shunting during systole. So the blood is being shunted directly to the right ventricle into the pulmonary artery. So the right ventricle will not see excess blood during diastole, to cause any dilatation. So the blood shunts during systole directly in the pulmonary artery, which will cause pulmonary hypertension or pulmonary dilatation. And then it goes to the lung to be oxygenated, returns back pulmonary veins to the left atrium. So the first chamber will see excess volume is the left atrium, so it will be dilated. Then excess volume to the left ventricle during diastole, so it will be dilated, and then the shunt through the VSD could cause right ventricular hypertrophy because of pulmonary hypertension. So in ASD, it is the left ventricle, left atrium chambers dilated, and in ASD, it's the right side where they are dilated. Another pictures of some other VSDs, and sometimes they are being divided whether they are related to the inlet, or sometimes they call it outlet. So it depends on whether it's related to the let's say the inlet side, or they are related to the outlet side. Sometimes they are divided into subaortic or subpulmonary, depending on where exactly the position of the VSD. PDA is the connection of this or the persistence of the duct between the aorta and the proximal left pulmonary artery. It is in hemodynamics similar to the VSD, where the blood is shunted directly to the pulmonary arterial tree. So the right side, right atrium, right ventricle will not see this excess amount of blood, but it is the left side where it will see the excess volume of blood. So in a PDA, in a VSD, left atrium, left ventricle are dilated, and dilatation of the pulmonary arterial tree, which will lead to pulmonary hypertension and might lead to pulmonary pulmonary hypertension and then right ventricular hypertrophy. Again, similar to ASD, VSD, PDA, if the amount of the shunt is not correlating with the size of the ASD or the VSD or PDA, sometimes it's not good news, sometimes it's a bad news, saying or indicating indirectly that there is a pulmonary hypertension. And similar to what we mentioned earlier in ASD and in VSD, that's important to comment in other congenital associations, defects, or pulmonary hypertension in order to decide the management and the prognosis of those patients. This is CT showing, of course, the size and the shape of the PDA. It's important in cross-sectional imaging, of course, to describe the shape, the length, the diameters from the aortic end and from the pulmonary end, because similar to ASD, to VSD, the shape, the length, the width, the amount of the shunt could decide whether to close or not to close, and how to close the PDA, whether surgically or by percutaneous. So sometimes the PDA would be closed percutaneously using occluders to occlude the shunt from the PDA. There is sometimes during measurements in cardiac MRI, it is really important to measure the shunt by doing the flow in the LPA and RPA. In a normal subject, the sum of the net flow in the main pulmonary artery should be equal to the sum of the RPA and LPA. So if you measure in the flow in MRI 10 milliliters in the main pulmonary artery, then you should be able to measure 6, for example, on the right RPA and 4, for example, on the left main pulmonary artery, because the normal distribution is 60 to 40, because the right lung, as you may know, right lung is larger than the left lung. Again, the sum should be equal to the main pulmonary artery, but in a PDA, this equation is going to be disturbed because there is shunt of blood from the aorta to the LPA. So it's important to measure the LPA after the PDA, so that the sum of the LPA plus RPA minus the flow in the MPA would give you the amount of the true QP/QS. Sometimes the blood flow could reverse through the PDA from the pulmonary to the aorta, but this is when pulmonary hypertension takes place. Epstein anomaly is the next presentation. Thank you very much.